This particular picture shows an individual who has the signs and symptoms of cirrhosis of the liver. And so it really affects every single system within the body. You guys can look at page, let's see, 1019, and it goes over that. But you have what we call metabolic hepatic encephalopathy. You have spider angiomas. You also have what we call petechiae. These are signs that you have ineffective clotting. You have a liver that has a lot of fibrous tissue. We've already talked about that. You have a lot of different dilated blood vessels because you have increased pressure in the liver. You have muscle wasting. Your palms are red. Your skin is yellow. It's itchy. You have a large distended belly, and that is called ascites. If you're looking at page 1019, it is showing you all these different things. And once again, for instance, just look at the skin, okay? And under the skin, the integumentary, it talks about being jaundice, having spider angiomas, palmar erythema, purpura, petechiae. You want to make sure that you understand all of these. The spider angiomas and the purpura and the petechiae, for instance, these can be due to abnormal clotting. So these can be due, for instance, due to clotting. You look at, for instance, the neurological. You have hepatic encephalopathy, peripheral neuropathy, ascites. You need to make sure that you understand what these are. Portal hypertension is a complication of cirrhosis. And what happens with portal hypertension is you have increased resistance to blood flow through the liver. So everything that's behind it, because of this increased venous pressure, suffers. And so just from portal hypertension, we'll talk about esophageal varices a little bit later. That's a complication of portal hypertension. Spleen is enlarged, and you can see what happens when the spleen becomes enlarged. You also have hypertension. You can see a patient will develop hemorrhoids and have ascites. Okay, another complication is hepatic encephalopathy. So the patient develops cirrhosis. Then from the cirrhosis, they actually develop the portal hypertension. From the portal hypertension, they develop shunts. These shunts then stop the blood from going through and being detoxified by the liver. It then passes into the systemic circulation, not filtered, returns into the body and reaches the blood-brain barrier. Where it crosses the blood-brain barrier, the main culprit being pneumonia. And as the pneumonia accumulates, this alters the patient's level of consciousness, often putting them into a coma. This is often a terminal complication. If you look on page 1021, there are a couple of symptoms that are specific to hepatic encephalopathy, the asterisks. And this is where you actually have your patient put their hands extended in front of them, then they flex their wrists, you push on them, and you are actually trying to elicit a flapping tremor. The other is the factor hepaticus. This is a sweet, musty odor that the patients often develop. You can smell it when you, get down close to their mouth. It's because of the lack of breakdown of byproducts. Again, just going back to page 1019, making sure that you guys are going through this figure, which is figure 44.6, understanding, knowing what these different terms mean. And as you can see, no system is untouched when someone develops cirrhosis. As far as diagnostics go, obviously you want to do the liver function test, a CBC, see if they are anemic, coag studies, where are we, are they at risk for clotting, your electrolytes, bili levels. Your ammonia level will tell you if it's elevated, if they're developing hepatic encephalopathy. Obviously, you could do an ultrasound of the liver. Upper endoscopy, especially if we want to check, you want to do an upper endoscopy if we're going to check for the esophageal varices. Okay. Liver biopsy if you're unsure of the underlying cause or they're possibly a candidate for a transplant. There is no, obviously single med that can cure cirrhosis, so it's more of a symptomatic treatment. We give aldactone. Aldactone will actually help decrease the ascites, which as would a paracentesis. Lactulose and neomycin are actually given to decrease the ammonia levels. Remember, ammonia levels cause hepatic encephalopathy, and so we give lactulose and neomycin. These will bind with the ammonia, help clear it from the body, and hopefully improve their level of consciousness. So we would give these to improve a level of consciousness. Beta blockers and mDOR actually help with the esophageal varices. And Cirrhosis is an anti-anxiety medicine. It's not hepatotoxic, so it is actually the drug of choice when we need to give them for something for anxiety as compared to like Ativan or Xanax. Nutritional support. This 2 grams is actually sodium, so they're often on a sodium-restricted diet. Along with that, a lot of times they're given diuretics. A lot of times they're also on fluid restrictions. They can also be placed on a low-protein diet, possibly less than 60 grams a day. And the one thing that's not on here then is that they're often on a high carbohydrate diet. Another complication is esophageal varices. This is the result of the portal hypertension. So the portal hypertension actually results in dilation and enlargement of the veins in the esophagus, and that is what you're seeing here, okay? A dilated, enlarged vein in the esophagus. The problem is this varice has a very fragile vessel wall, and it can rupture and bleed easily. And so when it ruptures and it bleeds easily, that obviously produces a life-threatening situation. And so that's what this is talking about here. If the varices bleed, it's life-threatening. First priority is that we make them hemodynamically stable. They're going to need a lot of IV fluids, and they're probably going to need blood products. So that's if they rupture. When we know that someone has esophageal varices, then we tell them, okay, you should avoid certain things. You should avoid alcohol. You should avoid aspirin or NSAIDs. You should avoid foods that are irritating. When we know that they have varices and they're at risk for bleeding, we can do something that's called banding. And that's what you're seeing here, where they go, and this is through an EGD. There's a special instrument that they can actually place a band. It's almost like a Ziploc tie on the varice to kind of tie it off so it will not bleed. When you're looking through here, scleral therapy, that is, there's a medication that we can give through a needle that will sclerose these varices and help them to not bleed. And then the Blakemore tube, you guys will learn about the Blakemore tube when you guys learn about upper GI bleeds. The Blakemore tube is utilized when someone is bleeding. It helps tamponade or shut off the bleed. So we're not going to talk about the Blakemore tube at this time. Ascites is yet another complication of portal hypertension. It's the accumulation of a large amount of like watery fluid in the abdominal cavity. It has a little bit of protein in it. It's extremely uncomfortable for the patient. It makes breathing difficult. And so what we can do for ascites is we can, place them on a restrictive diet. We've already talked about this: high carbs, low protein, low sodium. Give them diuretics. We've talked about that. But you can also do what's called a paracentesis. A paracentesis is where a healthcare practitioner actually advances a needle into the abdominal cavity. It is connected to a drainage system, and we drain off a large amount of the ascites, or the fluid that's in the abdominal cavity. When it says here it can be used for diagnostic or therapeutic, that just means diagnostic if we need some of the fluids to see what the fluid is comprised of, what's actually in it, versus therapeutic, that makes the patient more comfortable, makes it easier to breathe. You can take off a pretty significant amount of fluid, so we have to watch for fluid shifts. We have to watch for low fluid. We have to watch for electrolyte imbalances. If they take off a significant amount of fluid during a paracentesis, they might need some colloids, such as albumin, to help stabilize their blood pressure post-procedure. A tip shunt just allows blood to be bypassed around the diseased liver. And the reason a TIPS is helpful is it helps decrease portal hypertension, and if you can decrease portal hypertension, you'll have a decline in esophageal varices, ascites, systemic hypertension, all the things that go along with portal hypertension. And then the last thing would be is a liver transplant, and a liver transplant is only done for people who have cirrhosis due to certain issues. So for instance, if someone has liver cancer, then obviously they're not going to get a liver transplant. Someone who is actively abusing alcohol and has a cirrhotic liver obviously is not going to get a liver transplant. And we'll talk about nursing care of the patient who has cirrhosis in the classroom.